Great. Hi, everyone. Welcome to House Healthcare. It is Thursday afternoon. We're going to talk about budget adjustment today for DVHA, Department of Vermont Health Access. So we'll hear from them. We'll try and have some time for a little committee discussion. And then we will hear from Department of Mental Health tomorrow. And then tomorrow afternoon, we'll have much more of a committee discussion where we will have to decide what our policy or approval is to appropriations. So, yes.
Just a time frame? When do we have to get that back to appropriations?
I would like to do it by the end of tomorrow, if not definitely on Tuesday.
Not tomorrow.
Yeah, it's very fast.
Next tomorrow?
No, not next tomorrow, tomorrow.
Okay.
So I think what we'll do first, because I'm not sure if you've been in here, so let's do some introductions. So we'll start with us, and then if you can introduce yourself, and then we'll go from there.
I'm Melanie Carpenter. I represent Memorial 2, which is Wolcott, Belvedere, Johnson, and Hyde Park.
Alan DeMartin, I represent Enosburg and Montgomery.
Melissa Black, and I represent Northern Essex.
Lori Houghton, Essex Junction.
Introducing
We'll get to, you go ahead.
Daisy Berbecco, I represent Winooski.
Leslie Goldman, Wyndham 3, Rockingham, Westminster, and Brookline, which is the Bells Falls area.
Art Peterson, I represent Rutland District 2, which is Wallingford, Clarendon, West Rutland, and a part of Rutland Town.
And Mari, you want to introduce yourself?
Sure, Mari Cordes, Lincoln, Bristol, Moncton, and Starks.
Topper?
Topper McFawn, I represent Barrytown and Williamstown.
And Topper is vice chair. Bobby?
Bobby Farley's Rubio, I represent Barnet, Reigate, and Waterford.
And Brian?
Brian Chino from Burlington.
Great.
It's Albert coughing.
And I know he's really coughing. And I think that's it. But you got our whole committee.
Yep.
Sorry. Virtually and live.
I'm Stephanie Barrett. I'm the CFO of DVHA. I may look a little familiar because I don't think I was in this committee at all last year. When you were next door, I was in occasionally.
Yes.
But I was at the Joint Fiscal Office for 25 years before moving over to DVHA. So.
Great.
I'm Alicia Cooper. I'm the Director of Managed Care Operations for DVHA. Glad to be here today. Thank you.
Great. Wonderful. All right. Turn it over.
Awesome.
Oh, Alex, I'm sorry.
I'm not at the table, but hi, everyone. My name is Alex McCracken. I'm the Director of Communications and Legislative Affairs for DVHA, and I may also look somewhat familiar from my time working as a committee assistant in the last 2 sessions.
I have talked to you so much over the last couple months. I just felt like everyone has talked to you just as much. So
Please, I want everybody to talk to me.
Yes. Yeah, he's very responsive. So if you have deep issues, give Alex a call. All right.
So you have 2 documents that were sent to the committee. One is a narrative. That's what we'll walk through. And then one is what's called the ups and downs. It's a document that's probably more appropriations appropriate.
Yeah.
So if we're starting with the narrative document, it's several pages long. And what I'll do is walk through the pieces quickly in some areas where you stop me if there's questions.
Perfect.
We'll start with the admin budget. I won't spend a lot of time on that, but in the administrative budget, there are a couple big moving pieces around our contracts, and this is.
Sorry, Stephanie. I'm really sorry about this, but I'm thinking we take a step back and set the context. I think everyone knows this, but so this is budget adjustment. So we passed the budget.
Yes.
That went into effect July 1st, right? And so it's been 6 months. And when we come back into session, there is this process of budget adjustments. I don't know if you want to.
Incremental changes of what we see since if under 6 months of operating, since you passed the budget, this is a mid-year truing up of our best estimates. And all budgets are estimates.
And just so I understand, we're looking at June 30th. Correct. And that's the addition or deletion that it will take to get there.
Yeah. So you passed a budget with spending authority for DVHA in our 4 appropriation lines. And that started July 1st. And we've been operating under that, but we also update and foresee changes that are needed for this current fiscal year. And in a couple of weeks, you'll get the governor's proposal for the next budget year.
Okay, right.
So this is just for the mid-year adjustment for the current fiscal year that we are in right now.
Based on the numbers that we approved last year.
Yeah, this is the incremental change from what we say needs to change up or down. for a given reason from what was enacted.
And we do it every year.
We do it every year. Yeah.
Great, sorry.
That's okay. That's good. So in our administrative budget, in our contract area, and I've said this in every committee I've been in, the biggest surprise to me when I went to DEVA was just how many agreements exist in DEVA. But updating the contracts line item in our administrative budget is not, what we're seeing is that the funding sources matter in our budgets. And in the administrative budget, we need to make a fairly significant adjustment upward on the general fund and a very significant adjustment downward on the federal funds. And that's a function of items being left flat and not properly adjusted in the past, maybe being covered in the pandemic era where we are unable to cover it. When we closed last year, we had to have monies transferred into our admin budget to help us close around our contracts because it hadn't been updated. That's a very clear signal that something's off. And that was in my first month being there. And so that's what you're seeing. And you will see it again when you see the next budget because we have to bring it into the base and get the base correct.
So can you give us an idea of what a contract, like a type of contract you're talking about in this situation?
So we have some very significant IT contracts. We have a contract with Gainwell, our fiscal agent. That's a very significant contract. So the contract has gone up over time, but the funding, the general funding source, it maybe didn't go up with it. We have contracts with Optum. We have a variety of different types of contracts across the department. Some on the clinical side, on the business side, consultants, a variety. But some of our major contracts, and I give you a few examples. Maximus is our call center contractor. Those are the types of, we have contracts that are very small to contracts that are very large.
That's helpful.
Yeah.
Okay.
And then we have one other moving piece of money in the budget adjustment, and that is for the MDWAS project that had a significant infusion of general fund dollars last year. This is another $600,000. It's essentially neutral in its nature. It was money that wasn't expended in the central office that's circling around and coming back to DEVA for this project. In the first phase, the data lake phase of this project is underway. The vendor's on board, that's going well. And, we have several stages of this project to get our data and our analytics modernized so that it is useful to policymakers, to us as business users. That is the goal, and hopefully a lot of reduced stress on the folks that need to rely on these systems.
And is there a timeline on, it's on here, 2027?
That's it for the whole project.
Right.
Yep.
And when it says it's in black, then you're good right now for the BA.
So the black is the black is an up, okay, and the red is a down from what so that's what I'm trying to signal.
I just wanted to
Yeah.
So you need another $600,000 in state funds
for this project.
Right.
But overall, you're asking for 1.6 million.
So all funds, all appropriations, we're going down by 1.6 million. But it matters which pieces. You have to.
But I'm trying to understand the overall.
Yeah.
So overall,
our total spending authority that we are asking you for in this budget adjustment is actually a total down of 1.683 million.
And that's good for us. I mean, we don't have to, we're not asking,
It depends on where it's going down from. I mean, it depends on.
And that's all funds.
Right.
So when it's general fund that's going up, those are the state funds. Those are everyone wants that for everything.
Right, so overall, yeah, it's great. DEVA's budget is being reduced by almost 7 million. But where is it going up and where is it going down? And do our policies align with where the money's going?
okay, thank you.
So those are the moving pieces in the admin budget. And now we're going to move to the program budget. And the first piece always in the program budget in DEVA is caseload and utilization. And as you probably know, the baseline for the DEVA program budget is a consensus process with DEVA, central office of the agency, finance and management, and joint fiscal. And we have a consensus around projecting what the caseloads will be by our Medicaid eligibility groups that we budget on and our cost per case, our PMPM. And so what you are seeing here summarized is the caseload utilization change that the newest consensus that we've come to, which was presented to the emergency board next week, because it is the only budget in the state that's done this way. They adopt those caseloads and PMPM, and that sets the box for everyone around the baseline for this budget. And so what you see, if you're looking at the little chart at the bottom of page 2, the total expenditure is coming down by 5.8, 6.2 in the global commitment line, up a bit in the state only line, and then down again in the non-waiver line. But in total, $5.87 million down, the total spending authority. At the same time, this is not, in B307 is not in our budget, but total state funds need to cover that is going up. And that's very unusual. And it's the nature of the particular Medicaid eligibility groups where the caseload is changing. And that is the new adults without children is going down as we expected. We took a modest down when we did this consensus, when we built the budget. We're seeing the trend coming down a little bit more, but we only get, that's a very highly matched group. And so it doesn't save as much general fund and other Medicaid eligibility groups, either their cost or their caseload is going up in some of the ABD categories. And that's a outcome of the unwinding. Some people have been locked into their Medicaid eligibility groups for several years. And now, children are moving into adults, and some of the adults are moving into age blind and disabled categories. So that movement is happening at the same time. So it is a very more dynamic and higher risk of error in our budget forecasting for this baseline. That will start to smooth out after we get fully past the unwind.
Okay, so I'm going to try and summarize this. Because I see a couple people looking at me. So Stephanie, correct me if I'm wrong on this. So basically what is happening is, Medicaid has different populations with different match rates that come from the federal government. So I'm going to totally make this up. But let's say you have the Medicaid adult with no children at a 90-10 match rate, meaning we pay 10%, they pay 90%, federal government pays 90%. And let's say that population is decreasing, which means our 90% is decreasing with it, right? But we don't just have this is where I think I need correction. We don't just have a bucket that says this is the 90-10 match rate, and so therefore those are those funds. It's all the funds together, revenue comes together. So when 90% goes down, we get less money from the federal government, which might be pushing us up over here.
Yeah, it's especially if the Medicaid eligibility groups that are at 43% match rate are going up a bit.
Right.
And there's a handful of groups that are purely general fund, like our cost sharing, our Dr. Dinosaur expansion. Those are all purely general fund dollars. And so when those costs go up, they're 100% general fund. And so that's, in total, we're going down, but the general fund share of that is a different dynamic than you would expect.
That help?
Because of the nature we're in.
Can I see if I understand it? I'm sorry. So it's almost like payer mix, right? So if you're looking at it, you have a set up population, but your mix of what you get changes with the population so that it shifts.
And I'd say what we can draw from the federal government based on who we are paying an expenditure for. That's what drives it underneath. So
if I understand this right, then because of the change in the payer dynamic, the population dynamic.
Exactly.
Then we are getting $6 million less from the federal government, which then and also requires us to pay $3 million more, or 3.6. Is that correct?
Yes, that's on that first line. That's exactly right.
Okay, thank you. All right.
I understand what we're saying, but just so I get the real piece of it, that 4.4 million in the general fund is something the Vermont taxpayer must pay for.
Yes.
Okay.
Yes.
Thank you.
And this goes back to our conversation, Art, a little bit of why Medicaid doesn't pay the cost. This is a little bit of a separate conversation, but doesn't pay the cost of and that's because the state has to fund part of it and our funding fluctuates, or we choose not to fund it, or whatever the case might be. But
You have a lot of demands on that funding.
But the 10-90 split that you talked about might be different. It might be 20-80, 30-70, or is it always?
It's different.
It depends on the dynamics of the family or whoever's getting them.
Well, no, it depends on the category. So can you?
So the new adults that do not have children are the expansion under Obamacare that get the 90-10 CHIP, which are children at a different income level than general children. They get a slightly elevated FMAP. We have had experience in the past with CMS having enhanced FMAP, but those are the two main categories of eligibility groups that have different.
What's that split for the CHIP?
It's at 30.
It's like 37.
37,
yeah.
Okay. But if we don't have enough of those and have more of the 1080, we get.
Can I take the correct on it?
Sure.
So imagine you have different groups of people that all have different eligibilities. People come into Medicaid through different doors. It could be they have an illness, it could be they have like either age, and their income and other stuff. Up front, everybody's on Dr. Dinosaur or Medicaid. Behind the scenes, we put people into these what's called Medicaid eligibility groups.
Yeah.
We like to call them buckets, and people go into different buckets, right?
Yeah.
And so that new adult was a bucket created as part of the Affordable Care Act, and that got a separate match. Each of these buckets, most of the buckets get a standard match, but some have the enhanced. That one has 90-10, CHIP has 70-30. Most of them are the typical 55-45. So what's happening is we're less people in the 90-10 bucket, but then we're seeing more people in the other buckets that have higher costs. So you're seeing, you might lose 5,000 people here, but that doesn't offset the 3 people in this group, which are an expensive group, right? So whack-a-mole.
And it's not just always more people, it can be more cost. So, as people move off of Medicaid or switch in their Medicaid eligibility group, the stayers might be a higher cost population, the higher PM. So we have to think about those dynamics as we're doing this analysis as well.
Okay, so the kids that are stuck, kids tend to have a lower cost, and they're stuck in there. But with the redeterminations coming out, those kids are now going into an adult group, and they have a higher cost in that bucket.
Gotcha.
Seeing that as well.
It's hard to predict in general.
That's what we're trying to predict.
Well, it is based on actual experience of expenditure.
Right.
So not every person that's enrolled uses this services in the same capacity. Yeah.
Okay, so
That's a reminder on our FMAP match, just for.
I will send Claire my little cheat sheet.
Thank you. Appreciate it.
okay, great. Let's move on.
So number 4 on the bottom of page 3, this is the buy-in and the Medicaid savings programs that we pay for currently. And so this is the state paying for the Medicare premiums for the folks that are both Medicaid and Medicare eligible. That's the buy-in program. And then the Medicare savings programs, which are the 3 programs that we pay the premiums for. Eligible, they're not necessarily eligible for Medicaid, but they're eligible to have their premiums covered through Medicaid to buy them into Medicare. And that's why they're in 3 different categories, 3 different line items of our appropriations. And these are the incremental changes. And these reflect the change in the premium rate that the federal government charges the states for that buy-in for the half year. So that's what's reflected here in number 4.
So basically the premiums went up and so costs go up.
Yes.
Okay.
It's black, so.
That means
we need
more money.
They cost more and we need more money to cover it.
I always picture black as good, sorry.
Yeah, that's
What I'm.
I know, it's a little confusing for us non-financial people.
Oh, God.
So now we're into a couple, the last one is like buy-in, clawback on number 5 on page 4. This is also a federally driven, the last federally driven change. This is the clawback. It goes back to the start of the Part D Medicare benefit. It is how the federal government in part financed that benefit by realizing that that benefit would save the state's money, and they claw back every year a calculated amount from every state for that savings, and that is going up as well. And that's what's reflected here. And you'll see both buy-in and clawback again when we get to the big bill in a few weeks. So that's just the Fed's telling us we're going to give you a higher bill and us asking you to fund that higher bill.
So 4 and 5 are out of our control.
Yes.
Okay. Okay.
And then we have 2 net neutral pieces happening in 6 and 7. Family planning services. If you look at the health department's budget, you would see the equivalent down of this money. The money is simply moving from the health department to our budget to be paid for out of the MMIS system through DIVA. So there's no change. It's not an actual change in cost. It's an up to us. That's why it's in black in our budget. But if you looked in the other budget, you would see
a down.
Yeah.
Okay.
And then 7 is also net neutral. This is the safety net appropriation or funding. Right now, it's living in Section 307, which is our global commitment, but it's a global commitment investment, so it needs to come down and be in the state-only category. So that's what you see, a 0 for state cost. This is simply moving from one of our buckets to a different bucket.
Sorry, I'll be right back.
Okay, so the next item is the rate alignment. And I'm going to let Alicia Cooper explain that one.
So on an annual basis, Vermont Medicaid tries to ensure that the methodologies that we are using where they align with Medicare have all of the elements of those methodologies staying in alignment with any changes that are happening on the federal level. So in particular, this year, we looked at changes for our professional fee schedule, our outpatient prospective payment system, which covers outpatient services in hospitals, and our physician administered drug fee schedule. All of these fee schedules and methodologies are things where we essentially take the Medicare methodology and then implement our version of payments based on that Medicare methodology. Annually, Medicare makes some adjustments. Sometimes they make significant policy adjustments, and sometimes their adjustments are relatively minor. And we try to make sure that we are updating on the same schedule that Medicare is updating so that we're not wildly divergent from how Medicare payment policy is affecting our Medicaid payment policy. As you'll see, there's no dollar amount associated with this line, and that's because this package of updates was intended to be budget neutral. Effectively, for each of these updates, we tried to ensure that the changes would be as close to $0 as possible. And I think in aggregate, the changes together relative to the overall annual expenditure are 0.002%. So it's almost 0, as close to 0 as we can get, which effectively allows us to make those updates without having a significant impact on the budget mid-year.
I'm sorry, are you saying that you've aligned them by, say, moving RBRBS one way, offsetting it with the outpatient prospective payments? Is that how you're getting to neutral, or?
Each one was looked at independently as neutral, and when we look at all of them together, it should also yield a neutral.
You're not moving one bucket to another bucket to make the whole neutral?
No. But if in each analysis, if they're coming very close to neutral, when you add them all up, we would expect to see that the total stays neutral.
Okay.
Yeah.
Any questions on that from anyone?
So 9, 10, and 11 are increases in our budget from last year for changes or new things. 9 is breast pump supplies. We have always covered the breast pumps, but we have not covered the supplies, primarily the storage baggies. And so we are out of compliance with HRSA and CMS guidelines. And so starting in January, we are now covering those supplies, and you'll see this fully annualized in the next big budget. So that's number 9. It's pretty modest for half year. 10 is the Medicare economic index being applied to the FQHC and RHC payments. So this is a 4.6% increase. We do this annually, and you'll see the fully annualized version when you get the budget. And then 11 is hospice rates. And this is bringing us up to be compliant with minimum rates from CMS recommendations. So do we have any questions on those?
Yeah.
No.
I'm just curious about minimum rate. What does that mean, minimum rates? Is there a range, or they just say you have to do X?
So annually, CMS will tell each state what essentially the floor of payment can be for hospice services. And so this increase would bring Vermont Medicaid rates to that floor for this annual cycle. There's nothing that prevents the state from exceeding that floor for payments, but availability of funds.
Okay, but we've been below the floor up until now.
The floor changes on an annual basis, so we were compliant with the floor for the last 12-month period, and this brings us into compliance for the new 12-month period.
Thank you.
And just to be clear, 10 and 11, we have no choice in.
Correct.
Go ahead.
So 12 is Brattleboro Retreat. So we pay the Brattleboro Retreat on a set alternative payment method. And so this is not an increase in total to the budgeted annual amount for that, but the patient mix that we're seeing, who we can pay for and draw a federal match on in the retreat depends on, needs to be updated. That's what this is reflecting. And so we need to move part of the total alternative payment budgeted amount out of the global commitment where it's matched and into the state only where it's not matched, because we cannot draw match on forensic stays or for stays longer than 60 days. And that is for the entire stay. If you're longer than 60 days, the entire stay, the 60 for stays can't be matched. So that's what we're seeing here is the adjustment of moving. It looks neutral because we're moving $4 million from one place in the budget to another. But on the state fund side, it is not neutral because we cannot draw the match and that's a function of our previous estimate of where the patient mix was. But based on the way the year closed and the way we're seeing through the first half of this year, the patient mix, this is our best estimate.
Is that usually that large?
So this alternative payment method is, I think we're in our third year of it. That's relatively newish. And there's been in the rest of the system in mental health, some constraints earlier in the year. And so it may be that the fact that the retreat was the primary provider of these services for a significant part of the first half of this year, it's driving this, and maybe it will change as more capacity comes on in other places of the mental health system, but that's what we're seeing right now.
Thank you, that kind of answers the other questions.
And that brings us to number 13.
That was the one I told.
I have a question, sorry, before we go to number 13, because I have a feeling that's going to ask a lot of questions, and I apologize for having to step out. And maybe I'm not reading my red and black numbers correctly, but this all seems like we owe a lot. So how are we getting to a positive 1.6 million down?
So
what's not in here, that would be in the red.
So the only thing that's not in this narrative that's in the red is the application of carry forward in our state only appropriation. That's just a one-time application of resources to balance, the entire budget. That's part of that. But that's the only, because the downs and we're adding all the funding sources together.
I think
so. We could go through the spreadsheet here because that's the negative 1.6 is the sum total of all the funding sources, all the appropriations compared to last year. And that $4 million application of carry forward is a part of driving that negative 1.6.
Okay, and that's what we're not seeing.
It would look positive if we didn't have that.
Okay.
Yeah.
All right, thank you. Okay, number 13.
So I know we have been with this committee many times in the past to talk about our Medicaid Next Generation ACO program. As you may recall, we have been contracting with OneCare Vermont since 2017 for this Vermont Medicaid Next Generation ACO program. And we have been continuously contracting with them since. This particular line item relates to the 2022 performance year, which runs on a calendar year basis. We, after the close of the calendar year, wait a number of months to make sure we have complete data, and then we perform a year-end reconciliation process. And that's why you're seeing the 2022 settlement in our conversation about a budget adjustment for fiscal year 24. With this program, DVA and the ACO agree upon a price for services within this definition of total cost of care services for a population of attributed Medicaid members. And we have some risk sharing provisions around that agreed upon price, such that if the ACO's actual expenditure at the end of the year is above the agreed upon price, providers are assuming some financial risk for that expenditure in a way that Medicaid wouldn't have been buffered against in the past. And on the reverse, if the actual expenditure is less than what we expected or that agreed upon price, the ACO and its participating providers have the ability to share in the amount that is the difference between the actual expenditure and what we had agreed upon. We calculated this difference for the 2022 performance year, and just to put it in context, the overall agreed upon price for the Medicaid attributed population of approximately 126,000 Medicaid members was around $330 million. And so approximately $6.16 million is the amount that is being paid to the ACO because their actual experience was less than that agreed upon price. So this is our financial obligation as the state per our contract to the ACO. There's another portion that's also factored into the reconciliation at the end of the year where we essentially make sure that we made the right payments for our attributed Medicaid members every month. And sometimes we don't make the right payments, and that can be for a number of reasons. But we had I'd say, larger than usual adjustment for some of these differences in how members were being classified in the 2022 performance year. And I will tag team with Stephanie to make sure we're explaining this clearly.
So I'm just going to interrupt. So when you say member, you are saying a Vermonter whose insurance is Medicaid.
Yes, correct. So what we have in our system is every member has an eligibility group. This is what Nolan was talking about earlier as we think about different buckets for individuals. And we use those different groups to determine how much the ACO is going to be paid based on how much service an individual in that group is likely to require. So typically, someone who is a child utilizes less service than someone who is considered eligible because they're aged, blind, or disabled. So the rates of payment for those individuals are different. There's also a difference between a general child and a general adult. I think that's the important thing to remember here. Because of the public health emergency, Medicaid had a continuous coverage requirement for eligibility. And during that period of continuous coverage, we did not make any changes to members' eligibility category designations. So when we got to 2022, we had 19, 20, and 21-year-olds looked like they were still children in our system.
Okay.
So when our system makes payments on an automated basis on a member level each month, it was paying out child payments for all of those individuals. But per our contract, those are considered adults, and we should have been paying a higher level. And so the second component of the reconciliation is effectively us making up the difference for all of those child payments that should have been adult payments. And as you can see in the second part of the write-up, that accounts for approximately $5.7 million. I'll note that this is a dynamic that we expect will also show up in our reconciliation for the 2023 performance year, because we were still, for much of that year, under the continuous coverage requirement. But now that we've been resuming our redetermination activity, it will be less of an impact for 2023. And then in 2024, it should not be an element of the reconciliation.
Okay. Melissa? I'm just wondering, is that not something we should have anticipated?
I think it was sort of a timing combination of how the payments were being made mechanically in our system. Prior to 2022, it was a more manual process where we were having to submit a file of all of the members on a monthly basis to say what the payment should have been. That was, I would say, prone to human error. And so we looked to make this adjustment to our process to ensure it would be more automated and less subject to month-to-month variability.
And I will say, in terms of anticipation, when that decision was being made, I hope you'll recall that the PHE kept getting kicked out. We thought it was going to end here, and we thought it was going to end. So
pandemic, right?
Yes, the public health emergency. And so the feedback loop, hindsight is 2020. I wish we had thought about it, sometime in early 23, that a change we'd made when we were entering into the 22 calendar year should have been, thought through again as the pandemic health emergency date was extended. And that's where the gap was.
And I just want to, if I can go back to the 6.16 million, just so I'm clear, basically we contracted and said, OneCare, we're going to give you $330 million for this bucket of people. And they only spent 323, close to 24. And so we have to then pay them the 6.16 million. Is that where that part is coming in? Am I understanding it right, or am I oversimplifying it?
There are some additional steps in the calculation, and if you ever want to do a deep dive, we can come back and do that. But effectively, yes, we sort of agreed upon the price of 330, but we didn't pay it all out over the course of the year. And so when we see what the actual experience was, we see that we have an obligation to get up to that price. If the total had been in excess of the 330 million, we wouldn't have had the same kind of financial liability.
Can I just ask a follow-up? And this is getting off BAA a little bit, but the contract with the 330, is there anything about, the whole point of the ACO is quality. For their $6 million in savings, do they have to show some quality measures to be able to claim that, or has that not been looked at yet?
There are quality measures, and the quality performance on an annual basis affects the calculation of sort of the financial accountability in either direction. So basically, they are eligible to receive less if their quality performance is poor. They're eligible to receive more, sort of up to a certain amount, if they have good quality performance. And it's kind of on a continuum. So we look at a score, and the score determines whether or not there will be any discounting of what the payment will be.
Okay.
And this 6 million that is going back to the ACO, part, if not all of it, is then given back to the providers.
Correct. All of it is.
All of it. So it's not like the ACO
Go to the bank
now
account.
has $6 million. It's flowing down to the providers who provided the care. So that's, yes, it's a cost to us, but it's a cost we knew could happen. And it shows, if the quality measures are good, that our providers are providing good care, and then they're gonna get money for that, which is good, which is a good thing.
And we actually wanted to happen.
We want,
And the point is, we want them
That's how
to
the
be
ACO works.
incentivized.
Right. Any other questions on that?
So the last two items don't have a dollar amount with them.
Okay.
Number 14 is the 12-month continuous enrollment of children that's a federal requirement now, starting in January 2024. This does not have a cost estimate. And we do think a budgetary cost estimate listed here. We do think it has a cost embedded in it in terms of the fact that what this change in regulation does means that children can't move off the program if there's a change in their household income in between their redetermination period. So if the family's income a year out is above the eligibility, then the child would move off the program. But in between, that can't happen. And we think that has a modest cost. But it doesn't have a budgetary cost because of where we're starting from in terms of building the 24 budget and looking into the 25, coming out of the continuous eligibility for everyone under the PHE. And so we don't believe that it has a budget impact to us in 24 or 25. But we do think it has a cost. We think it's a cost that's actually lower than what was presented when the rule was presented, because that was an estimate that was made a year and a half or so ago or 2 years ago. But the analysts thinking through it and understanding what it does, that's where we're landing. But we note it here because it is a change in policy that we are under now.
Right. So just to summarize, so this is a change in policy again from the federal government. So normally people have to send in requirements, income requirements, or if there's a change in income change.
They're supposed to self-report, yeah.
On a monthly basis. And so at any time during that time, a child could be removed from Dr. Dinosaur because of the parents' change. This is saying that can't happen. Who's ever on as of January 1st will stay on Dr. Dinosaur for that year. And then in January they go through, or whenever
their anniversary of the redetermination is. Yeah.
They will go through the eligibility requirements again.
Yeah.
And how many kids are in Dr. Dinosaur?
So there's
I know it's
approximately like 57,000 in the general kid population, and then 8 in S-chip or so.
8,000, you mean 8,000?
8,000, yeah.
Okay. Like 45 seconds.
I feel like I should know this, but I'm used to seeing it on a spreadsheet, and there's a lot of numbers on that spreadsheet.
You see a lot of numbers in the course of a day.
But it's well over 60,000 children. It did the continuous eligibility for 3 years did swell those populations.
Right.
And some of the decline we see in that are kids actually moving into different categories, adult categories, but that is also a category that's coming down in caseload.
So in this example, like categories 1 and 2, so 12 months from the date of child, okay, so category 2, the child is no longer a state resident or an income change.
Yeah.
That could decrease our cost. But based on something you just said, a child who turns 19 and goes then to the potentially adult Medicaid,
yep.
There's a higher cost for that from a Medicaid perspective?
So there's a higher estimate of what an average per member per month for an adult is, then it's higher for children. The individual child may have no change in cost to us.
Right, but overall.
Yeah.
It's about 65,000.
Total on Dr. Dinosaur right now. Okay, and then number 15? I'm sorry, does anyone have any questions on that? Number 15.
I know, let Alicia explain this one.
So building on our prior conversation about.
Oh, I'm sorry, hold on. Topper has a question. Topper?
Yeah, Madam Chair, thank you. I have a question on the quality indicators.
Okay.
Where would one go to find those quality indicators? And where would one go to find out if those quality indicators were met?
This is for the ACO.
Yeah.
We can send some documentation as a follow-up to this discussion. We've got, I think, links to presentations that we've done on the 2022 performance and some other materials that might be helpful.
So I don't know if you heard that, Topper, but they're going to send us that information.
Okay.
Great.
Thank you.
Thank you. All right, number 15.
So continuing to talk a little bit about our ACO program, in our 2024 calendar year contract, our contract period that just began, we included the ability to implement a new pilot program that we are calling the Global Payment Program. And what this would do is kind of augment some of the payment provisions in our existing ACO model for providers who are receiving fixed prospective payments by looking at how much they're receiving from Medicaid in their fixed payment and looking at what they might still be receiving from Medicaid in their fee-for-service payments, recognizing that through the ACO model, their fixed payments are for the attributed population, but the attributed population is set at the beginning of the year. There are always some folks around the edges who are not eligible for attribution, and there are new Medicaid members coming on at all points during the year who would not have had the opportunity to be attributed. So if you think about a large independent primary care practice, for example, the majority of their Medicaid payments for their attributed Medicaid members could be coming through a fixed payment arrangement from the ACO, but then they would still be receiving fee-for-service payments directly from DVA for any other individuals. This Global Payment Program pilot would enable us to kind of convert those fee-for-service payments into another complementary fixed monthly payment. So they would have kind of 2 monthly payments from Medicaid, one for their ACO attributed population, one for everybody else. And together, that should comprise almost all of their Medicaid revenue on an ongoing basis. We've been thinking about this with OneCare, both in terms of independent primary care practices who have been receiving prospective payments through their comprehensive payment reform program, as well as hospitals who've been receiving fixed prospective payments as part of their participation. As you'll see here, there's no dollar amount associated with this line item, and that is because DVA is able to cover implementation for a sort of small sector of those independent primary care practices to turn this program on. In the event that other larger organizations were to participate as well, we would need additional funding to support that because there is sort of a cash flow challenge for the Medicaid program when we are implementing prospective payments newly for a certain set of individuals and when we're still paying out fee-for-service claims with a lag. So there's a window of time when we're effectively paying twice. And that means that there is a sort of one-time cash need for the department to sort of turn it on. So you can see that because there's no dollar amount associated, we're effectively reflecting that we've implemented this for that smaller group of primary care practices so far, and our contract gives us the ability to implement it for larger hospital organizations should we identify a potential funding mechanism.
And you're doing this in anticipation of potentially joining the AHEAD model. Yes, so which we talked about a little bit this morning and need a lot more information on. But that's the anticipation because there is a requirement, correct, for Medicaid to have a global budget in that AHEAD model.
Precisely.
Okay.
Yes, we are hoping that while this isn't strictly speaking a global budget model, this would get us a lot closer to something like a global Medicaid payment for these participating entities. It would give providers a little bit of an opportunity to understand what having all of their Medicaid revenue coming in predictable monthly cycles means for their business. And it would give us some learning as well around what it means for our budgeting cycles, what it means for our system implementations and so forth.
Leslie, and then Art.
So you said something about paying twice, and I just wonder what that means, how much, and is it the cost of doing research? And maybe it is.
It's a timing issue. So claims are paid after the fact and the prospective payment is paid up front. And so if you're making this switch and you're saying the things that were formerly fee-for-service claims, we're going to pay you right now, the estimate of that. But there are claims from 6-8 weeks back that are still running through the system. So that's a cash flow issue to our budget. And so the twice is where they overlap.
Twice to you, not
Twice,
not to you, not to the provider.
yeah, we're not paying twice for anything. We're just, our budget has a.
Clarity, got it.
I wondered, and Laura, you may have as much information as these folks on this. How is Medicaid redetermination going? Is that completed? Is it done? Is it, what progress and what impact does it have on all of this?
So we're
You know?
pretty much midway through. The the full unwinding and completion of redetermination should be done in July or August of 2024. When you see the next budget, the big budget, you will see the full rollout estimates of that.
So there's people still on Medicaid who really shouldn't be right now,
So they're
based on their
Eligibility.
eligibility.
We're no longer eligible, say.
Yeah.
Well, they still have to redetermine that.
Yeah.
Right,
Yeah.
yeah, so we don't know.
We don't know. Yeah.
We don't know, because
But-
they
Yeah, we
haven't
don't
gone through
know.
the
Right,
process.
right.
But we are seeing a decline in particularly certain Medicaid eligibility groups that we expected to see a decline in because of the outcome so far of redeterminations that started in April.
And I'm sorry, just to interrupt, but we will have Diva come back specifically to talk about this. I keep asking you a
My
question.
reason for asking is if that was speeded up, say we had, all right, start in April and you staff up and get it done, would these numbers be lower if that had happened?
Well, probably not, because we would have had to pay for a lot more additional staff. I mean, I don't think we can really make that determination. Sure, if something went faster, we would get to the end faster, but Diva does not have the staff.
Well, I understand, but
We also
I'm
have
just trying to.
system constraints and federal requirements that have come in sort of after the fact that we have to adjust to as well.
Okay, so, all right, so, but it has an impact on these numbers.
The enrollment will always will be the driving force of everything we spend.
Yeah, just wondered.
Yeah. And maybe they're not related, but that pilot program with the 2 fixed payments, will that change the need for sorry, I need my glasses, an ACO settlement? Will that no?
No, so what we're doing with the global payment program is the vehicle is our ACO contract, but we will do all of the calculations for that segment separately from the calculations of the sort of underlying ACO program to keep them clean and make sure that we're understanding each one distinctly. We expect there will also be some reconciliation on the global payment program component itself. I think further down the road, once we have a little bit more clarity about whether we participate in the HEAD model as a state and whether we're able to implement larger global budgets for other providers, the need for reconciliation might look very different.
So just to be clear, so OneCare is they're administering the people who are already attributed. You're keeping this bucket of the freshly new ones. You're doing that and you're administering it at Diva, correct? Is that what I'm understanding?
We're keeping them separate, but the ACO is effectively administering the payments on behalf of Diva.
So you're giving the ACO the money and they're sending the money to the practice?
Yes, per their contractual arrangement.
What they do for everything else.
The practices. Yes, I think
the ACO.
Because they do that. They do the contracting, they do the.
I have a mess over here and a mess over there.
Okay.
You had another question?
Oh, well, I didn't know I'm sorry, I didn't.
So that was all. I
just wanted
was
to
trying to
clarify that.
understand how those maybe affect, and you clarified it. So good.
She has a question and then we're gonna have to wrap up because we have a 2:20.
Yeah, no, I wanted to talk about the clawback a little bit. So without the clawback, how much would you be coming in here asking for?
So if we didn't have
Not the clawback, I'm sorry, the carry forward. Sorry, I was.
the carry forward, so without the carry forward, we'd be coming, the carry forward is state only carry forward, 309. The carry forward is $4.4 million. So it'd be 2.8, 1.6 minus 4 from that, so $2.8 million up is what we'd be asking for instead.
Meaning we would owe.
Yeah, yes.
And like, what exactly is the carry forward?
Carry forward is just money we didn't spend last year.
Is it money that Diva didn't spend last
It's
year?
general fund money that Diva didn't spend last year in one line item because we, so for example, it's in our student line item. We had carried a $1.4 million estimate for the cost of the Dr. Dinosaur expansion. That came in at like $270,000. So that's part of the 4.4. I think there's a couple other costs that also came in lower. And so that's the reason we have it. So it carries forward from one year to the next. It's just one-time money. It's just available, so we don't have to ask you for it.
Okay.
Apply it.
It's just, I just want to be clear that it is money that was allocated to Diva. It wasn't some other.
No, it was allocated to us in our budget in '23. We didn't expend it. It carried forward to the next year and we are applying it here.
Okay, and that's how much, that's the total of how much we have that was carried forward, or is there more money out there?
So we
that hasn't been
carry
spent?
forward general fund dollars. You don't carry forward federal fund spending authority. It just dies at the end of the year.
Okay.
Is there a more direct question? Is there carry forward dollars from the Diva budget that is going to another budget to help their?
So the Global Commitment Fund, which is our 307 appropriation, that's a mixed dollar. A Global Commitment Fund dollar is a combination of a state general fund or state dollar and the federal dollar. And up in section B301 of the budget, which is the central office of the agency, there's 301 is called Global Commitment. That is where you see the component pieces of expenditure for all the Global Commitment Fund throughout the agency. So we get nearly $1 billion of Global Commitment Fund. DMH gets $500 million. Dale gets $250 million. That's substance use gets a fairly significant chunk. All of that is financially started in that central office. And so there is component, the funding components of that are separate from DVA.
But that, so if there was, sorry, I'm hijacking your
please.
questions, but I know where you're
You know
going.
where I wanna
Yeah.
go.
So that money that sits in B301.
Yeah.
If there was, and excuse my probably horrible financial language here, because I'm not really, I don't know the language, but so let's say there was a carry forward of $5 million. That wouldn't necessarily go to like Agency of Commerce and Community Development. It would stay within Agency of Human Services to affect healthcare at some place.
So if there was a carry forward there, I think that's a conversation you want to have with the central office folk.
Okay.
Administrations can do different things.
Good answer. We will talk with them.
Is there an itemized listing of where the carry forward is coming from? Like you mentioned the Dr. Dinosaur expansion, that I've been asking for 2 years where that money went to. So here's where it went.
It didn't get spent, and so it carried forward to the next year, and now it's being applied here as one-time available resource for our budget adjustment.
Okay.
So can we get a list of all the money that has not been spent?
So that, so the 4.4 is the amount in DIVA that has not been spent. And we can tell you what drove those component pieces.
Yeah, I'd be interested.
We'd like that, yes.
Sure.
That'd be great. Thank you. Leslie, did you have another?
Okay. That's my thing. We, for instance, the Medicaid expansion for the non-citizen kids, like, we didn't know how many were getting.
Right.
So our estimates were too high.
Yeah, we're not
They just want to understand the component pieces. Yeah.
I just
want to understand it.
Unpaid position, or unfilled positions, right?
Yeah, that wouldn't be in the program budget at all. Anything related to positions for us would be in our one administration line.
So thank you very much, Stephanie. It's great to have you in the position you're in, and we're excited to work with you. We'll see you, I'm sure, again during the budget session.
Some of these will be very familiar again.
Wow. Yeah.
But I'm not a financial person either. So I would just like to have a time at some moment to sort of connect the narrative to the spreadsheet.
Oh, that's easily done.
Okay,
Maybe you can connect with them offline, because I don't think we'll do that in committee.
okay.
That would be great. Is that okay if they connect with you offline?
Sure. And
Or
if-
Nolan,
if-
Nolan can do it. Or two.
Either one of us.
Yeah,
Nolan, you're my guy.
that'd be great. Thank you both very much. We appreciate it. Thanks for all you're doing for Vermonters. You guys do a lot of work. All right, is Julie here? Yes, she is. She's online. Hi, Julia. Sorry, I need to say Julie. So, we have Julia coming with us. Do we have, I think she's still trying to connect, maybe. Is there anything on the webpage on this?
Yes.
Okay. Is she trying to connect? Hi, can you hear us? We can kind of hear you. Okay. I think she's still connecting. Trying to figure out where the. So this is Howard Center. So this is we'll give her a minute. Thank you, Alex. This is a request that is not in the governor's budget adjustment. You all know how this works. The governor puts out his budget adjustment and then in a little bit his budget, and then folks who serve Vermonters come forward and say, well, you know, we also need some money, and they ask for funding in the budget adjustment or the budget. And so this is one of those circumstances. Howard Center came to us with a program that they run today that they're losing funding on. And so they're asking us to support funding it. So we will hear what the program is, we can ask our questions, and then we'll have a conversation later about whether or not we include it in our recommendation to appropriations. Sound good?
You have a question? When we get to that part, when we discuss it, do you help frame like how we do our priorities?
Yes, we always love that conversation in this room because it's so easy to prioritize.
I'm looking for a shirt.
Yes. Were you here during budget?
No.
No. Okay, that's what I. Okay.
Yeah.
Okay.
That is.
Okay. Yeah.
That's where we get to know each other.
So Julia, are you there?
It's a moral document.
Oh, Julia.
Can you tell her she can? Okay. Julia, if you can hear us, we cannot hear you.
She's muted.
Yeah.
Yeah, you look so cold.
I know. In that picture, I know.
Nick, do you represent them?
I do.
Oh, here she is.
I'm here.
Hi, Julia. Thanks for joining. So if you can, I kind of gave the committee a preview of what we're trying to do. And so if you can introduce yourself for the record, and then we'll listen to your testimony.
Sure thing. Hi, everyone. I'm Julia Paradiso. I'm the Director of Access and Intake at the Howard Center in Burlington.
And sorry, the Howard Center is the designated
Sure,
agency.
the Howard Center is a designated agency in Chittenden County.
Great, thank you.
Sure. Do you want me to go?
Yep, please.
Okay, great. Hi. Thank you all for inviting me and for the opportunity to speak today and for you to take into consideration funding our cultural liaison program through the end of our fiscal year. I'm the Director of Intake at Howard Center, and Howard Center is the largest designated agency in the state, serving over 19,000 clients annually with 1,600 employees. So today I'm coming to you today with a request for funding for our cultural liaison program. At Howard Center, I'm responsible for the team that helps new clients identify and register with the Howard Center programs they need. Essentially, it's the front door to our organization, and that includes one of our newest programs, which is a program serving immigrant, refugee, and asylee community members. And we call this program our Cultural Liaison Program. And going forward, when I speak, I'm going to refer to those that we serve as our resettled community. So the origin of our program, the Cultural Liaison Program, began during COVID lockdown in 2020. There was a large COVID outbreak in Winooski in the Bhutanese Nepali population. And it was determined that the community wasn't aware of how to mitigate the spread because there was no connection to the greater community supporting and informing them. Schools were closed. A group of confirmed human service and community members met, and out of those meetings, fundings for services was established for our resettled populations. So what that meant for Howard Center is DMH received a grant called the Health Equity Grant. And that was through the CDC, through the Department of Health. And it was for a 2-year funding of $267,000 to create a 3-person team to work with our resettled community members to decrease disparities. And in the spring of 2023, an additional $80,000 was added through the same grant. This funding wasn't renewed, and Howard Center is requesting $166,000 in the FY24 budget adjustment to continue the Cultural Liaison Program through the end of our fiscal year. So the Cultural Liaison Program, with this funding we received thus far, we've created a robust program, and with 3 individuals from 3 different resettled communities, they are working as our Cultural Liaison Program members. And the main purpose of our program is engaging, building trust, and being ambassadors of Howard Center and Howard Center services. Our cultural liaisons are not from every resettled community. They couldn't be with just 3, but they have the same lived experience, which is vital to engaging with those clients. And so we strive to demystify and destigmatize our services, our Howard Center services, and bring our resettled community members into services so they do not end up in crisis. Our small team is increasing community partnerships, and in a short time has engaged over 100 families. While our cultural liaisons are not language interpreters, they are interpreters of Howard Center services. We hear from many in our resettled community the language that only crazy people go to Howard Center and that they do not want to be seen in that way in their country's community. Some of our resettled community members believe that if someone is crazy, that's God's way. Our team seeks to inform our resettled community about Howard Center services as another way to help. Our cultural liaisons work with individuals and leaders in the community, and they provide information and resources about all our services at Howard Center. So Howard Center, as you probably know, provides developmental disability services, substance use services, and mental health services. We have found that meeting with community leaders is a vital way to build that trust that allows us to work individually with resettled families. Our cultural liaison program has met with resettled country leaders, like the Nepali leaders, Somali leaders, and we've established, and we also work with established organizations like Association for Africans Living in Vermont, AALV, or USCRI, United States Committee on Refugee and Immigration. We've met with the Islamic Society of Vermont. We've met with Connecting Cultures, Vermont Afghan Alliance, and many schools. Howard Center has also translated many of our brochures into different languages and works with ease with many of our different interpretation services. Our biggest focus, though, is on mental health and suicide prevention. Our team is trained in identifying and referring folks who have suicidal ideation, and we closely work with our crisis team, which is called First Call for Chittenden County. Our cultural liaison supervisor was eager to be trained as a mental health first aid trainer. And mental health first aid is an 8-hour class. It's a skills-based training class that teaches participants about mental health and substance use issues. So our cultural liaison supervisor has held trainings for the Bhutanese Nepali community, through the Congolese community, the Burundi community, the Islamic Society of Vermont, and the Family Room, to further spreading information about how to identify mental health issues and support and where to get help. Our goal is to identify and get treatment before our resettled community is in crisis. So we serve many different resettled families, and in the past 2 years, we've served nearly 100 resettled families, and we've provided over 1,200 services across all ages. These resettled families are from 13 different countries and with 10 different languages. And the most popular languages that we see right now are Nepali, Swahili, and Somali. And some of our services, I'm going to give you a snapshot of what our services look like. We worked with an older Bhutanese Nepali woman, and she was identified through our street outreach program. as someone who was disconnected and isolated from services and family and living in a motel outside of Burlington. This client was far from her family. She didn't know how to use the bus, was without food regularly. She had major medical issues. Our team connected with this client and helped her with transportation, finding ethnically appropriate food, and working together. She was able to secure a Section 8 project-based housing apartment and now regularly takes the bus to medical appointments. And that was within, we've been around for 2 years. So that's in a 2-year period. And that was a lot within that time. Another example would be an adolescent of a resettled family that attempted to hang himself while he was at a school function. Howard Center School social workers engaged with our team, our cultural liaison team, to meet with the family. And the parents did not seem to understand what their child did, nor did they understand the severity of his feelings leading to the attempt. So our team was able to meet immediately with this family and gain trust because they shared a country of origin and the same language. And working with the parents, they were able to provide services, get the child into services, and the child is now engaged in therapy and is attending school. Another thing about our cultural liaison program, which spreads wide across our organization, is that we help individual resettled families, but we bring awareness to the Howard Center staff. So as I said, Howard Center staff is 1,600 employees. So we bring awareness to these employees about issues with acculturation, isolation, with our resettled community, and a better understanding of how to serve them. We often consult with other programs, and our team has been vital to Howard Center and have helped staff improve understanding of different cultures, and in turn leading to better outcomes for our resettled community. We continue to reach out to many communities to try to spread the word as best we can and to continue to build trust. And this month we're hosting a meet and greet at 3 different housing authority locations in Winooski and in Burlington to raise awareness about Howard Center services and resettled families. This funding, it's a meager $166,000, will go a long way for our Burlington community. So I want to thank you for your support and consideration in funding our program with $166,000 for this fiscal year and helping our resettled community to lead to healthy lives in Chittenden County. Thank you.
Thanks, Julia. So I have a couple questions and then I'll open it up. You say your fiscal year, when is the end of your fiscal year?
June 30.
June 30. And so is the expectation then that you would need additional funding for the next fiscal year?
Well, we're searching for funding for the next fiscal year.
Okay. So this funding would, without this funding, would this program shut down?
Without this funding, this program will be not fully funded and will add to our deficit.
Okay. Daisy and then Leslie.
Julia, I'm Representative Rebecca from Winooski. Thank you so much for being here today and for what you do for my community.
Thank you.
It's difficult to emphasize how grateful I am and how many constituents come to me from the community that this program serves because of the need for what you do, especially the elders who, they're refugees. They have suffered traumas and they're desperately in need of culturally appropriate care, and there are so few places that they can get it. And I understand that there are also, because of the nature of our funding streams, there are also minimal places that will pay for the type of people providing these services who are actually culturally competent, like linguistically competent. And so I just have to applaud you for being able to empower those folks with the lived experience to get out and nurture healing in our community. And just want you to know that it is making a difference. And I'm deeply aware of the need to help you. I wonder if you can speak to, what would happen if this isn't funded. I'm aware of, I think people are starting to become aware of the need for this kind of care, real community connection and the value in that, and also the benefit and the health outcomes. So we were hearing earlier today about the AHEAD model, which has, it's an acronym, and somewhere in there is health equity. And so I'm hopeful that there will be a deeper appreciation for approaches like yours or this program's. However, were this not to be funded, how difficult would it be to find staff like these three folks that work for you right now? If this were ended and funded and not funded, and then eventually something like the AHEAD model were to be implemented and people said, hey, wait, that was actually a great program, let's bring it back. How hard would it be for you to find these folks again?
Well, thank you for everything you said, Rebecca. I really appreciate your understanding of this, and glad to hear that you're here and you're from Winooski. I think it's a great question, and I also think it's sort of a crystal ball question too. I don't know if I can fully answer that, but what I can say is that if this program is not funded, not only does it sort of destabilize the three people that are here, with their uncertainty of why would they want to stay here when they know the program isn't funded, and then at Howard Center, but it also destabilizes all the work we've done so far. We've reached out to so many different communities, and you talked about the elders. All those country of origin leaders we worked with are all the elders. They're all the elders we're talking to about bringing folks in and just to learn about what our services are and not to be afraid of them. So I think what would happen is that community members might be left out in the cold. I think about the work that we've done so far at Howard Center. We have really shed a light on, how you use interpretation services correctly, what our clients need, and our organization has existed without these for many, many years. And it was long overdue that we had cultural liaisons in our organization. And I was tasked to develop this program and to hire the staff that we have. The staff that we have are so compassionate and skilled. And I think without this program, I'm concerned what would happen to our resettled community. I'm recalling a time where USCRI connected with us around a client, a Nepali older man that was in the hospital for over 24 hours waiting to seek services because they did not know that they could have called First Call and probably gotten the services they needed there. So it's just, I think the information is lost. The trust is lost. Our community members who've spent all this time working with the community leaders and the individual community members, that trust is lost. And I think it kind of brings us back to a point where out of all the work that we've done, it would sort of be erased in a way.
Thank you, Julia. Leslie?
Thank you. Yes, I'm from the southern part of the state, so I'm not as familiar with your work as Daisy is, but what she said was amazing. So that's great. I'm curious to know if you got any feedback from the administration about why they chose not to fund it.
This wasn't a program funded by the state.
Oh, it was a grant.
Yes,
So it was a grant.
a federal grant that ran out, that is not
ran out, and that's why they're asking for this money. Thank you.
Yeah.
Thank you for your work.
Thank you.
Julie, Alan, do you have a question?
I guess so. Of the 19,000 patients, are they coming from all over the state or mostly, where do your patients come from?
Mostly Chittenden County, but people do come from different parts of the state. But I would say, we do have people coming from different parts, but I'd say the majority of them are from Chittenden County.
Thank you.
Mm-hmm.
Yeah, so I just want to be clear, the 19,000 clients is for all of Howard Center?
Yes.
Okay, great.
And I knew that.
Yeah, okay.
Just
Brian?
Yeah, I'm not gonna put my camera on because I don't look good right now because I'm sick.
That's fine. That's fine.
I know I'm not a witness, but I do work at First Call, and I have to say that although the majority of the clients for the Howard Center are based in Chittenden County has become like the destination for people who've been displaced from all over the state, that there's hundreds and hundreds of people living in the woods here from all over Vermont right now who are constantly in crisis. And the Howard Center is helping people. So I just want to point that out because it's important for people to realize that, you know, we're not partitioned as a state, that we're interconnected, and that, you know, even if someone's here now, they might have come from somewhere else. So I just wanted to say that. Thanks.
Great. Thanks, Brian. Julia, are you familiar with the Bridges to Health program?
Bridges to Health?
Yes.
Is maybe not. Maybe.
Okay, and that's fine. You might not be, that's fine. It's a similar program, kind of, that was started out of Addison County. So I was just curious if you were aware of that, that's all. Thank you for the testimony. That was great. I don't think we have any other questions. So we'll consider this as part of our overall committee discussion on what we recommend to appropriations, and we'll let you know.
Thank you. Can I add one final thing?
Absolutely, yeah.
In regards to most of our clients from Chittenden County, they are, but I think we also need to think about Chittenden County is, Howard Center is the largest DA, and Chittenden County is the largest county urban center. And clients do come back and forth. And I think that it's important that we understand the majority, or a lot, the services in Chittenden County and in the Burlington area are in dire need. And we're also the biggest area that accepts refugees at this point to our community and resettled folks. Thank you.
Great point, Julia.
Considering.
Yes, thank you so much. Have a great day.
You too. Bye-bye.
And we are done for the day.